We finished parasympathetic, right? Okay. How is everybody feeling? Do we feel like it's too fast? Do we feel overwhelmed? Do we feel nervous? Am I saying or okay. So y'all want me to go slower?
No, it's gonna be fun.
No. Okay. Y'all need me to go slower. I'm really like trying to see where everybody is in what we feel comfortable with because we have the time, okay? I'm going to do a review for you guys as well, but I want to make sure that you're understanding because a review doesn't mean anything if you're not understanding anything. Because it's going to be the same thing that we talked about in class during the review.
I think with every class we've taken so far in IPAP, it's all about how the tests are presented. It's kind of how we study after that first test. So if we could see some example test questions, we can
And I think that
focus our studying.
So here's the what did you say? What did you say? No, you said it out loud. I need to hear it too because I want to laugh. No, this is the thing, right? Like I can give you a practice exam question. Your practice exam question, like, is one question that it will be several questions, right? But the questions that are on the exam aren't going to be like exactly like that because then I'm giving you the exam. You know what I mean? But I can direct you. And that's why I want you guys to listen. Like, I've been getting a lot of questions like, how do I study? What do I do? Like the outside resources to use. Your exam is coming from your slides, okay? It is coming from the slides. So if you have time to look at extra stuff, then have at it. But it's probably going to be more detailed than what I'm trying to do. Like, I want y'all to get the main ideas because you're going to see all of these drugs that I talk about with somebody else again when you're doing like your ologies and all your other classes, right? So like, I'm just like, here, these are the basic foundational types of things that you need for PHARM to be able to recognize them whenever you're learning how to actually apply them. So we'll get to that whenever we get to the review part, but I'm also like, I know y'all are worried about the exams, I'm worried about you retaining knowledge, okay? So that you can do well on the exam, but also so that you can take care of you one day. Okay, so like, I know that we work for grades, but we also like, it's the knowledge. Sometimes the exam grades that you guys get don't reflect what you have actually learned. And I understand that too, and that's why I always also try to tell y'all, don't beat yourself up. Like, no, we can't fail, but also understand that sometimes, some people, we just suck at taking tests, okay? Yes.
I just think the first pass, man, like, this is the first that a lot of us are seeing drugs, so like, if you go slower or faster, I don't think it's really gonna
Make a
help us
difference. It's still
because it's the
overwhelming.
first pass,
Okay.
so it's overwhelming. So
Okay.
I think, I mean, and I don't want to talk for the class, but like a review, seeing it after we get to study it and stuff like that, I think that would be more beneficial than.
Okay, so us doing a review on Thursday is probably not gonna help y'all. Want me to do a review on Saturday? Where you have more time to kind of look at stuff. Y'all have an exam on Friday too? No? Friday is gonna be tough because I'm gonna be in Florida and I get in late on Thursday. So I'm trying to figure out like what would make it beneficial for you all. For me to take like an hour or two out of my time while I'm there to do it. So if you want it on Thursday, we can do it in person on Thursday. What we can do is like a game and then kind of like if you have questions, just ask questions and they'll be on the weekend, whatever y'all need, just text me because I'm gonna take my computer and then you're gonna see it like again in your own space. So we'll still plan for Thursday to be our review during our class time. And then on the weekend, if y'all have any questions, even if I have to like WhatsApp you to write it out, we can do whatever y'all need on the weekend, okay? So we'll still plan for Thursday for a review. Somebody had their hand up somewhere. Okay, it was thumbs ups, okay. Okay, so that's gonna be our plan. So what we're gonna do, we're gonna do sympathetic nervous system. We're gonna look at our anesthetic meds, which is gonna kind of be a review of what we looked at when we looked at our parasympathetic nervous system. We'll see like some of our neuromuscular blocking agents again kind of come up. So when we're looking at these drugs, again, the way for your studying, when we're talking about the drug portion, another caution, please do not just focus on the drugs. You had several other lectures prior to us getting to these last 3 lectures that we're doing with medications on them. A lot of people who don't pass the first exam say, well, I was just focused on the drugs, and I forgot to look at everything else, or I rushed through everything else one time. That's like a good chunk of your exam as well, okay? So please don't forget that you have other lectures outside of these last 3 that we're looking at with the actual medications on them, okay? So when we're looking at our parasympathetic, we were going over that, the different receptors that we were talking about. What was my receptors when I was talking about my parasympathetic nervous system? Huh? Muscarinic, nicotinic, right? M1 through M3. And then what was my neurotransmitter? Acetylcholine. So looking at our drugs and how we're trying to affect those things and affect acetylcholine. What is acetylcholine doing? Looking at if they're indirect. Make sure you go over your mechanisms. Make sure that you're understanding your adverse effects is a big part of that that whole lecture. When you're learning those drugs a little bit better, make sure that you're understanding, all right, my agonist, this is what this class is doing as a whole, okay? Because it's typically like regardless of what type of agonist or what type of antagonist, your side effects are the same. You learn those side effects, then okay, these are my side effects, so what indications could benefit essentially from these side effects that this class of drug is causing, and then that's where you're seeing like their use. It is so cold up here, sorry, I'm shivering. Okay, so make sure, we can't complain about it being cold though, y'all, because when the AC breaks, we're like, oh. Okay, so I'm grateful that it's cold. But just make sure when you're looking at that, that's the easiest way to study that. Again, just pull out the little random things that you see if we're talking about a specific side effect. The same thing as we go through this. When we go through this, your big focus is going to be kind of learning what those receptors do so that you can understand, all right, what are the effects of my drug? If my drug is hitting this alpha-1 receptor, what am I expecting to see if an alpha-1 receptor is hit? What am I expecting to see if a beta-2 receptor is hit? Because once you get that part down, it's like, okay, I got this because I can remember this drug is doing this thing, and then here are my effects. The other thing with this, this portion is that in any of my lectures, I don't text you on pathophys. So like the very beginning of like a lecture, if you see it and it's labeled pathophys, I'm not testing you on that, right? That is your background for you to understand how your meds work, okay? So when we look at our parasympathetic nervous system and it's specifically talking to you about certain receptors and like what that receptor does, I'm not necessarily asking you that, but I might say like, hey, here's this drug and it's working on this receptor, what happens? I'm gonna ask you in the context of a drug, okay? So these first couple of slides that we're gonna go through, background about our sympathetic nervous system. The ELOs are listed here, and we're gonna do a little, what do you know again? So, our sympathetic nervous system, what is it responsible for? Fight or flight, right? What's our main neurotransmitter that's gonna hit those target nerves or our effector cells? Epinephrine, but more than epinephrine, we have our norepi is like one of the more predominant, but we do have epi as well. What happens if you give a beta agonist with a beta blocker or a beta antagonist? Right? They're counteracting each other. It's going to cancel out. When you hear agonist and antagonist, any class I give you, you should always be like, those two things don't go together. Drug-to-drug interaction, they're countering each other. Okay? What are the effects of an alpha-1 receptor? Does it excite? Does it inhibit? Excites, right? So anytime while we're going through this lecture and something excites, you're going to see the little, whatever this is, I think it's a koala, that pops up, okay? How, is it a koala? I think it's a koala. I got something wrong before with an animal with my clip art. So I'm going to do that so that we can remember, like, we're excited, okay? That's what that medication is going to be helping us with because it's hitting that alpha-1 receptor. What are our effects of a beta-1 receptor? Okay, so we're going to go over this because remember we have beta-1 and we have beta-2. So we're going to talk about them. And then what drug is an adrenergic agonist that is used for shock? Epi, right? So we'll go through some of these and try to remember kind of where everything is falling. When we're looking at this is just a breakdown showing us essentially how everything is working, right? So you have your peripheral nervous system, and we have our autonomic, which is going to be composed of our parasympathetic and our sympathetic. So we already talked about our parasympathetic, which was our rest and our digest. So now we're going to be focusing on our sympathetic, which is looking at fight or flight, right? Same photo that we saw before, so just looking at kind of where they stem from, what they're doing, what you are expected to see if that system is activated, okay? Also, the same picture of what we saw before, so when we were looking at our parasympathetic, we were looking at acetylcholine, whereas now our main neurotransmitter that we were talking about when we're looking at our sympathetic is going to be our norepi. We have epamine, we also have dopamine that we're going to talk about. So a lot of these things are going to be effective when we're looking at our sympathetic nervous system. Okay, so just make sure you also keep track of the difference between our systems, what our receptors and our neurotransmitter is that we're targeting. So this is just zoomed in, again, letting you know, right, I'm going down this neuron, crossing my synapse, which was also still that nicotinic receptor at that junction, and then we store our norepi and they get released by exocytosis across the synapse to that effector cell. Okay, so they're gonna bind to those receptors, and then you're gonna see some type of action occur. Whether it's an alpha receptor or a beta receptor, that will determine what response we get. Okay, so when we go over those receptors, we'll talk about, okay, this is the response I'm expecting to see. Looking at this is again just going over what my neurotransmitters are, and then looking at our signaling. So when we're talking about our norepi, it's made from us looking at tyrosine, and then you see it gets converted to L-DOPA, and then norepi, you have reuptake, so it's kind of still the same thing when we're talking about a negative feedback system. You're going to see that same negative feedback system in our sympathetic nervous system as well. So all I want you to know from this side is that you're seeing that we can have our norepi termination. So like when I'm trying to say, hey, I had enough, stop, I am going to see my COMT and my MAO are going to be the things that are going to degrade or turn off the effects of my norepi, okay? So I don't want any more action, I don't want any more stimulation, I don't want that response to happen anymore, I'm going to turn it off. Can you come get a chair from up here and take it back there if you want, or so that's what we're looking at whenever we're talking about our stimulation and our signaling that we're expected to see from our norepi. So if I want to stop it, what are my two terminations of norepi? COMT and MAO, okay? So think about that. If I inhibit those, what's going to happen to my norepi? Go back up, right? Because I don't have anything that's breaking it down, okay? So when we're talking about our catecholamines, just understand that these are going to be molecules that activate those alpha and those beta receptors that we were talking about, okay? When we have our different ones, they're listed there on the bottom, your norepi, your epi, and your dopamine that you have available for you whenever we're talking about this. Our drugs are going to mimic these catecholamines. When we made our drugs, though, we said, okay, we talked about this yesterday, right? If I have something naturally in my body that's going to be broken down, usually it's going to be broken down quicker. So if I make a drug, I'm making it to where it's going to last longer, right? Because I want to get that effect for a longer period of time. So remember that these are our endogenous, right? Like what our body already had available. And then our drugs are things that we made to last longer, usually, or to terminate them if we don't want them to have any effect at all, okay? So looking at this, just make sure that we're looking at the fact that if something is polar, is it charged or uncharged? Charged. And if it's polar, am I absorbing it? No, okay? So thinking about that, those are the same things that we went over before. Remember our fundamentals, a lot of that stuff is gonna keep coming back up, and that'll kind of help you remember some of the stuff with our meds. So if I have something that's polar, that means that it's charged, ionized or unionized? Ionized. Oh, so y'all are ready. We don't need to do a review. Yes, we do. We're all right. Okay, So when we're looking at specifically our norepi, what I want you to remember again is that it's going to activate our alpha and our beta receptors, okay? When we look at our alpha, we're going to go into detail about what happens when we activate that alpha, but essentially what's going to happen is you're going to have contractions, you're going to have vasoconstriction that happens. And so when we're talking about the net effect of something that's vasoconstricted, so if I'm a water hose and I'm open, right, things can flow through me freely, right? But as soon as I start to like clamp down on that water hose, the pressure that's behind where I've clamped at from my water source, like in between the water source and the clamp, now that pressure is going up, right? Because it can't go out. So if I vasoconstrict, I am going to cause my pressure to go up, right? Because now my water hose is shrinking, okay? So think about anytime you hear vasoconstriction, we're looking at our alpha 1. Okay, something has hit that alpha 1 receptor and has caused it to vasoconstrict. Therefore, I'm expected to see my blood pressure go up, right? Because I constricted it. I'm closing up my water hose. You see your beta 2. So where is my beta 1? Because y'all talked about this, not with me, but y'all talked about beta 1 and beta 2. Where are beta 1 typically located? What about my beta 2? Lungs. Okay, so you see here with my norepi, I have very little effect with my on my beta 2, but I have some. Okay, so I can expect to see like bronchodilation, things like that when I'm looking at my beta 2. And then you see the direct stimulant on the heart. So if I'm saying that I'm directly stimulating that, I'm going to expect to see my heart rate go up, but then I have reflex bradycardia because my body is always trying to keep me even, right? That homeostasis. So when I have tachycardia, what should happen is my body say, hey, hold on, calm down. And then I have reflex bradycardia to try to bring it back down. So that's what, anytime you see this, because you're going to see reflex bradycardia a lot, that's going to come in here. That's trying to say like, yes, I increased that heart rate, but my natural reflexes are saying, calm down, go back down. Okay, so reflex bradycardia, slowing it down. When we look at our epinephrine, so epinephrine is a really tricky drug, especially when you're just now getting introduced to drugs. So this has dose-dependent effects. So depending on the amount of epi or the dose of epi that I give, I'm going to see different effects occur. Okay, I'm not always getting the same effect. My dose matters. My dose is controlling what response I get. Okay, so you see whenever it has alpha and beta activity, but if I'm giving them a lower dose, I'm expected to see more of my beta activity occur. So when I'm looking at my beta, I have my beta 1 and my beta 2. So it depends on also which beta receptor it's hitting more. Okay, so this is giving you your net kind of response of what you're expected to see. No dose kind of taken into effect. I'll walk you through kind of what we're looking at. So your increased systolic blood pressure that can happen, or your blood pressure going up, is essentially happening because your heart rate is going faster. Okay, and the contractility is also increased. So if I am beating faster and I am squeezing, contracting harder, I'm going to see an increase in my my blood pressure occur. So that's your beta 1. Also, don't forget that your systolic blood pressure can go up because you'll probably also have some alpha 1 activation. And that's not on there, but that's another thing that's also causing that increase as well. Because I have vasoconstriction with my alpha 1. So if I vasoconstricted, we already said that I made my blood pressure go up too. Okay? And then looking at this slight decrease, we said that when we're talking about our beta 2, we're talking about the lungs. So if I hit my beta 2 with my epi, you're going to see some vasodilation. Not as much as I'm seeing the constriction that's happening and that increase in the heart rate happening. So that's why you have an increase in your blood pressure. The net is an increase in your blood pressure. Not saying that you don't still have that beta 2 activity, but it's outweighed by how much vasoconstriction we have and the increase in that heart rate that we have. Okay? So you still have that vasodilation, it's just not enough to overcome the constriction that we have. All right? So that's where you see that net increase of blood pressure. And then all of these other things, again, relaxes the bronchial smooth muscle that goes with that beta 2 activation as well. When we're talking about glaucoma, we'll look at this, but like that alpha 1 receptor, increased drainage of that aqueous humor, so letting some of that pressure out like we talked about yesterday, is one of the good benefits that we see from this medication as well. Looking at your dopamine, when we look at dopamine, you have beta receptors as well, but we also have dopamine receptors that can be activated. So we have our subtypes 1 and 2 that can be hit. So again, this is one of those ones that's dose dependent as well. When you have a higher concentration, you're going to see alpha-1 hit. Alpha-1 means what? Vasoconstriction. And so a lot of the times, just like we saw with our norepi, I'm going to have that vasoconstriction. My heart rate and everything is going to go up, but reflex bradycardia because my body is like, wait, why are we so high? So bless you. So you see again, where you have that reflex bradycardia trying to compensate to say, okay, calm down, we're going up too high. Okay? So looking at your low and your high concentrations, again, dose dependent. So we had two that were dose dependent. Our epi and our dopamine are dose dependent. Okay? So depending on if I gave them a low concentration versus a high concentration, what am I expecting to see? So I'm going to talk, when we go through the actual drugs, I'll tell you, because I don't really want y'all to focus so much on some of these doses because we look up doses. There's very few that I have to look at. So when we get to the actual slide, there's a slide on epi we'll talk about. All right, so this is what we were talking about with our receptors and understanding what your receptors are doing, okay? When I hit this receptor with this drug, what is my response that I'm receiving, all right? So when you're looking at your alpha-1 receptor, understand that it's excitatory, which is what I asked you with that pre-test question, right? Our what do you know? It's exciting, okay? So if I'm excitatory and I have my vasoconstriction, my blood pressure, did it go up or did it go down? Up, right? Because I constricted, I limited my water hose, my flow is not going as much. So I have more resistance. So that should help you also remember that you're having increased resistance, right? Because I've shortened or narrowed my passageway. When you're looking at my mydriasis, is that dilation or constriction? I'll ask you. Dilation, and then your increased closure of your internal sphincter. So essentially what you're doing there is you're retaining urine. So think about it if you're fighting somebody, right? These are all things that you need to make sure, like my eyes are wide open, I can see everything, I don't need to go to the bathroom right now, like I'm trying to stay alert, right? Because remember we were looking at sympathetic, fight or flight. And all of this is fight or flight, okay? Told you it's coming back every time we talk about excitatory. All right, so your alpha-2. When we're looking at our alpha-2, this is just understanding, I want y'all to look more so at the responses, not necessarily where they are. So when we're looking at our alpha-2, you see that we're talking about inhibitory. So alpha-1 excites, but alpha-2 is inhibiting. So here we see a decrease in my sympathetic outflow. So instead of me like, hey, I need to go, I'm calming stuff down when I'm hitting my alpha-2, okay? Inhibitory. So my blood pressure is going down. You see the inhibition of your insulin release, okay? So like that's kind of going down. So you're gonna have more glucose or sugar floating around because I don't have insulin to combat that. And then inhibition of lipolysis or like the breakdown of your fat. That's gonna also stop, okay? So I am inhibiting things. We'll go over this because this is talking about the affinity that our catecholamines have for that alpha receptor. So epi is more, if it had to choose between like an alpha-1 and an alpha-2, it's more likely to say, oh, I like alpha-2. Okay, so this is just, that's what we're talking about when we're looking at affinity. So anytime we look at anything that's inhibitory, it's a fox. It's a fox. I don't know my animals that well, okay? So it's a fox, and he is saying no. Okay, so anytime we talk about anything that's inhibitory, we're gonna have him come up. All right, so beta-1. You told me where beta-1 was, you told me where beta-2 was. So when we're talking about beta-1, I'm expecting to see some excitatory action, right? I'm expecting to see the contraction increase. So all of this kind of makes sense. When you're looking at the renin secretion in the kidney, we'll talk about that more next semester. So just understand that it's excitatory, more so we're thinking about our heart. When we're looking at our agonism that you have that's happening, okay? So increased contractility, chronotropy, inotropy, we'll go again on that more so next semester. Your renin and then your lipolysis increase, okay? So now excitatory. So think about, I have alpha 1 as excitatory, alpha 2 was inhibitory, but beta 1 is also excitatory. So now you see that your alpha and your beta 1s are both excitatory, okay? And then this is again just showing you some affinity. We'll look at that in a little bit. All right, so our beta 2 and beta 3 receptors. You very rarely are going to hear about beta 3 receptors, so that's why it's kind of down there at the bottom. It's something that's kind of a newer thing. I'm not going to really ask you a lot about a beta 3 because we don't really see it so much in drugs. So we are going to focus on our beta 2 receptors. So when we talk about our beta 2, again, this is going to be something that's mainly inhibitory, but when we're looking at the pancreas and what's happening from the pancreas, you'll see that that's kind of more excitatory in our responses that we're going to get. So you'll see increase in the glycogenolysis, okay, and glucose release, like all of that sugar and stuff is going to be released so that your body can start to say, like, I need to use this for energy, for that fight, okay? So we have mixed kind of responses when we're looking at our beta 2, so it's excitatory and it's inhibitory. When we're looking at this also, now we have where I can urinate, okay? So you have relaxing the uterine smooth muscle, so it's inhibiting that contraction. So now you can see where I was telling you about, like, some of this is going to be mixed in what we're experiencing with our excitatory versus our inhibitory. So whenever we were looking at this, we had kind of both of them having those actions, okay? Because my vasodilation, my muscles and livers, and the increase of the glucagon, again, helping me get that sugar out, increasing my glucose levels, all of that was more so of an excitatory action that we were having. Okay, our receptors. So that's what we were just talking about. We looked at what happens with my alpha 1, my beta 1, my alpha 2, my beta 2. Don't worry about beta 3, you're not going to see a lot of that. I put all of the synonyms of the words that you're going to see over on the right-hand side in the box for when we're talking about our agonists. Okay, so you see there's several different ways for you to say it. So just kind of keep an eye out for that, because depending on what preceptor you have, they may use a different term. And then again, with our antagonists, anti-against, right? Antagonist is against whatever we're looking at when we're talking about our agonists. So it's kind of the same thing that we did yesterday. You learn one, you're going to kind of see the other one happening, okay? So this is just looking at where they were located on this slide to give you a clearer look. So when we're talking about our alpha 1, which is why we're seeing a lot of effects with our blood pressure, that's because it's more so in the vasculature. Alpha 2, same kind of thing, but remember we said that was inhibitory. So that's why you see that presynaptic negative feedback system, right? Because it's stopping things, it's inhibiting things. Beta 1, we said the heart. 2, because I have 2 lungs. So beta 2 more so in the lungs. So you were talking about things with our glucagon or our glucose levels, okay? As what you're expected to see when we're talking about our beta 2. Everybody okay? Y'all got it. Talk to me, where are we at? What do y'all need right now? Y'all are still quiet. I need words.
We're absorbing.
Okay, you're absorbing.
We're locked.
Okay, so now you have the foundation, right, of everything that we're gonna need as we continue to walk through, okay? So when we look at these drugs, I'm going to tell you what to focus on. Please do not get overwhelmed, because it's going to be doses and different things, and I'm going to simplify it because I'm not gonna need you to remember some of that stuff for the exam, okay? It is going to be for your reference later. You may see it later. So I need you to listen to me while we're going through this, because there's a lot of stuff, and some of this I don't need you to worry about, okay? Not right now. You'll worry about it later. Okay, so we saw this. We saw this several times yesterday, right? So the same exact little chart that's giving us, here are my receptors, depending on which system I'm in, right? So same thing that we talked about at the very beginning of class too. And then what am I expecting to see whenever I hit that receptor? This is specifically looking at our eye and what the response is going to be in the eye. So if I have my alpha-1 receptor, I'm expected to see the mydriasis. If I hit my beta-2 receptor, I'm expected to see that relaxation, right? Same things that we talked about when we were looking at what our receptors did, is now just showing you in the context of specifically God, okay? So this is a breakdown, again, of our drugs and kind of how we're going to look at them. So you have your direct acting agonist, indirect acting agonist, and my mixed acting agonist, okay? So again, if I'm direct, straightforward, I'm just telling you what it is. My indirect, I was going to somehow indirectly help my main catecholamine, which was my norepi. So I'm in the background. Norepi doesn't know what I'm doing. I'm helping indirectly, right? And then my mixed action, this is going to be one of those ones where, like, when you see the drug, it'll kind of make a little bit more sense, but binding directly with the receptor and it's displacing the norepi. So an indirect kind of thing as well, right? If I'm displacing something, I'm like passive aggressive with it, all right? So that's kind of how you have your mixed action. And then you have your catecholamines, which are my natural ones, my endogenous ones, and then my non-catecholamines that I have, which are the ones that I said, I need to make this better. Let me make a medication, okay? So I have my alpha agonist, my alpha 2 agonist, so more selective with where I'm going, whereas my alpha agonist, I can hit alpha 1 or alpha 2 depending on sometimes the dose or just my affinity for that receptor. And then my beta agonist and my dopamine, right? Because these are the same catecholamines that we were talking about at the very beginning. These are the same 3 receptors that we've already talked about, our alpha, our beta, and our dopamine, okay? Okay, so starting with our endogenous, which are the ones that we were already kind of speaking about, now we're looking at it in the context of us using it as a drug. When we talk about any of these, let me go back. When we talk about any of these, all of these are going to be like an IV type of formulation. You're not going to see these in oral because what breaks down my catecholamines? My 2 things, COMT and our MAO, right? So if I give this and I let somebody take it orally, they're on their job. And it's not gonna work, so therefore there was no point in us giving it. So that's why a lot of the times with these, they're IV meds or you're injecting. When we talked about like our epi, they're gonna inject it, okay? It's not something that's gonna be oral. All right, so norepi, we already kind of see where on our chart, when we have this in our direct category, right? Because it's a catecholamine, it's directly gonna act on our alpha and our beta receptors. You see that we have more of that alpha, so it predominates. We saw this when we were looking at that very first kind of summary slide. The thing that you're going to notice about this is that this is one of those medications that we're titrating the dose to the response that we want to see. So a lot of your patients who are going to be on this medication are going to be your patients who are like in ICU settings. They may be in some type of shock and we're trying to like increase their blood pressure. So we'll have them, they're going to be on machines and several people are going to be monitoring them. And so you're titrating this dose to the response that you want to see, whatever that target may be. Sometimes we have different blood pressure targets depending on what condition that patient is in or how low they are, how low they are and where we're trying to get them to go safely, okay? Because we can't just like we can't quickly drop somebody's blood pressure down, we have to like slowly do it. We also can't quickly raise somebody's blood pressure, okay? So more of our alpha than our beta, and then because I have more of my alpha, not saying that I don't have the beta, but more alpha, you're gonna see more of that vasoconstriction happening in your patients who are gonna be taking some of your norepi. So again, told you shock. When we talk about shock, it could be several different causes as to why somebody is in shock. What we'll see a lot is going to be like somebody lost a lot of fluid. So let's say they got shot and they were bleeding and they lost a lot of that volume, their blood volume, right? So their fluid is down, their blood pressure is going to go down because they don't have anything to pump. They're losing it, okay? So when we talk about shock, this is what we're using this for. So we're titrating them. We're trying to get their blood pressure back up by our norepi hitting that alpha receptor, causing the vasoconstriction so that we can increase their blood pressure again. Their blood pressure continues to drop, we can potentially lose your patient, okay? So when we look at this dose, don't need you to remember it, just understand that it's titrated, okay? And you see that we're titrating it to that systolic blood pressure, or the top number on our blood pressure, to be between 80 and 100. So just understand, titrate it, okay? Don't even remember anything else about it. It's titrated to that blood pressure. I'm using it for my patient who is in shock. When we look at our adverse effects, just try to connect it to your mechanism, right? What is this drug doing? And when I have tried to like increase this blood pressure, okay, and let's say I increase it a lot, you may see where somebody ends up having now hypertension, right? I clamped down too much on those vessels, and now my blood pressure has gone up too much. The CNS effects of like the tremor, the anxiety, just think about like somebody like just I'm amped up now, right? Like I'm pumping them back up. So trying to remember this, and then cerebral hemorrhage, that's just because I've clamped down now, and so I can potentially, not saying that this always happens, but I can potentially increase that pressure that they're experiencing inside of their head, especially if they've already had some type of head injury. You can potentially see where this can be problematic, and then you're definitely monitoring them to try to make sure that you don't cause any more problems. Extravasation, essentially this is where you put your line in, and then let's say you were running it too fast, or it got displaced and like the medication starts to leak out of where you need it to go, and then you can experience tissue necrosis, so their skin will start to die. Sometimes before it gets that bad, what you will see is that they start to become hot in the area where you're running the line. Your pump may start to beep and tell you that it's occluded. Like that's for you to try to see, okay, like make sure everything is running okay. Touch their arm. Is it warm? Does it look swollen? Is it red? Those things are to help you know, like, okay, I should be okay. Ask the patient. Sometimes they will tell you like, oh, I feel like something is burning. Or, oh, this hurts. It shouldn't hurt once you have your line in and you're running your med. Okay? So if you hear those things, that's for you to be like, okay, I need to make sure that I don't have this extravasation occurring. Our interactions that you see. So you have your alpha blockers, beta blockers, and your MAOI inhibitors or COMT inhibitors. Okay? So when we're looking at this, if you have a blocker, right, and I'm giving it with something that is direct acting, like I'm trying to get this stimulation on my alpha and my beta receptors, but if I have an alpha or a beta blocker, it's going to stop me from getting those effects that I'm trying to see, okay? So that makes sense. And then looking at your MAOI inhibitors or your COMT inhibitors, that's going to make that drug last for a longer period of time. So if you don't need it to last longer and they're on one of these medications, now you're worried about having increased risk of side effects because I didn't need that drug around that long, right? So now you're going to see also more accumulation happening. All right, so all of those things come into play, going back to the PK stuff that we talked about, making sure that you're looking at your patient as a whole. All right, so our epi, we talked about our epinephrine and kind of where it was hitting. So when you're looking at this, you see that you have alpha 1 and 2 have equal activity and greater affinity than our beta receptors when we're talking about our epi binding. So I'm going to see more vasoconstriction than I'm going to see my activity from my beta receptors, okay? So that's why this is written that way. So your alpha 1 and alpha 2, there's really no preference. Whenever your epi is going in there, it's like, oh, where's an alpha? It's going to find one of them. If there was an alpha and a beta, it's more likely to go to that beta. Not saying that it doesn't touch your beta, right? It just it predominates when we're talking about our alpha. So you're going to see this as we go through a lot of the slides, and they may be written differently. It may just say alpha over beta, okay? Or it may be like alpha 1 greater than alpha 2 greater than beta, okay? So we'll see these as we continue to go. We already talked about the effects, right? So now this is going to start to become very repetitive because we talked about what the receptors, if I hit that receptor, what I'm expecting to see. So now, once you start to see these drugs, look at what receptor is hitting. Those are your effects that you're going to get, okay? Every single time. So that's why I like for y'all to look at the receptor activity in the very beginning first. And when you're studying for this, look at that first. Learn that first and then go to your drugs. It will make your drugs easier and it will kind of be like you're reviewing them. Once you learn this drug does this receptor, this drug does this receptor, you're gonna know what your clinical outcome or your results are from those drugs binding to those receptors. So increased cardiac output, and then because I do have some of that beta activity, then I can see my bronchodilation that's occurring, okay, with my epi. So that's why we like to see a lot of our patients who have any type of allergies, which is our clinical use. So if I have anaphylactic shock because I ate peanut butter and I'm allergic to peanuts, or I ate seafood and I'm allergic to seafood, I have my EpiPen, I give myself my injection, it opens everything back up, right? Because now I can breathe, because when I have anaphylactic shock, I'm typically having trouble breathing, things are starting to shut down on me because I can't breathe, okay? So when I give that epi, my epi is hitting all of those things to help me kind of open back up, especially that bronchodilation is a big thing that we need. Sometimes you will see this used to prolong the anesthetics that we're going to talk about. So when you are given an anesthetic medication, because I can cause some of that vasoconstriction with my alpha receptor, I can now keep my anesthetics in my system for a longer period of time. Okay, so this is enhancing those effects. It's an additive effect now because I vasoconstricted, my drug is hanging out a little bit longer in that spot that I needed, especially if it's a local anesthetic, right? And then I inject to where now it can't move. My epi is keeping that anesthetic that I chose to use in that spot. It's not going anywhere. It lasts longer, okay? So bronchospasms, cardiac arrest, anaphylactic shock, and then we just talked about the anesthesia. Your dosing, there's several different ways for you to give your epi, but remember it's not ever going to be anything that you're looking at as like I'm swallowing a tablet. So we do have where you can kind of nebulize. So when we talk about asthma, and has anybody ever seen where like we'll put, kind of like if you were to put an oxygen mask on someone, except we put nebulizer or we can put epi in that machine to then let them inhale the epi that way, okay? Versus the injection or versus giving them IV, okay? Our interactions, these look familiar? We just saw them, right? So same interactions, if I have my alpha or my beta blocker, because I have that alpha and the beta activity that's happening with my epinephrine, if I block those, I'm not gonna see the results that I wanted to see with my norepi, okay? And then the same with my COMT inhibitor or my MAOI or MAO inhibitor, I'm now making this drug last for a longer period of time, maybe longer than I needed it to last. Okay, so that could be a good thing or a bad thing, but it's still an interaction. Adverse effects, very similar to what you saw when we're looking at our norepi. Here though, you see that you have that hyperglycemia because remember, we can increase that glucagon when we were talking about our beta receptors, okay? And these had that beta activity. So that's why you see your hyperglycemia there. But again, this looks just like norepi. The difference that you see, I have this hyperglycemia as my adverse effect on here. All right, so start to like try to find the differences when you're looking at these. Dopamine. So when we're talking about dopamine, same thing as what we talked about before. Direct acting, we have alpha, beta, but now we also have our dopamine receptors that can be hit. This is a dose-dependent one, so that's what I want you to remember, that it is dose-dependent. When we look at what happens if I hit my beta receptor, I'm looking at my cardiac output. My alpha is more so that blood pressure, right? So I can see that I have that vasoconstriction, so I'm expecting to see my blood pressure go up. And then when I look at my dopamine, this is just helping you increase diuresis or their urination. You're not going to use this for that. We have other medications that are for that. So this is just a, how do you say it, like a side effect kind of us hitting those dopamine receptors, but not an indication for us to use it for just that. So if that's all you're trying to do is perfuse the kidneys or like diurese a patient, this is not the drug that you're gonna use for that. We'll talk about that next semester. Our clinical uses that you have, so again, we're looking at shock that we're trying to help our patients, whether it's septic shock, so they had some type of infection that is like attacking their body and they're going into shock, or if they have cardiogenic shock, which can be happening for several different reasons. Y'all will get that somewhere else, but they can have, there's several different types of shock, okay? So remember, cardiogenic or septic shock happening to our patients, an alternative to my norepi because I like norepi. Okay, norepi comes first, then I have my dopamine. And then you see that this is a pro-arrhythmic medication. So if we're concerned, especially with our patients who have underlying heart conditions, you see that your dopamine has a higher likelihood of causing an arrhythmia, which depending on what type of arrhythmia is caused, could cause someone to die. So that's also why you would look at this as a second line to your norepi, okay? So when we start to look at drugs, and as we continue to go through drugs, there's usually gonna be a first line and a second line to some stuff. Usually your first line medication has more desirable, and not all the time, but usually has more desirable effects than what your second line medication is gonna have. Maybe it's gonna help me live longer. It might have a mortality or a morbidity benefit, and my second line med may not. Okay, so we'll see that as we continue to kind of go through some of these drugs. And then when it looks like at our dosing, remember we already talked about this, we're not using this just to perfuse our kidneys for that protection, okay? So this is not the only reason why we're using this medication, all right? We're using it for something else, but we're getting that added benefit. All right, monitoring. EKG, you're gonna make sure you're looking at that. You're gonna monitor that urine output because we know that when we're hitting that dopamine receptor, that we probably are gonna have some stuff happening with our urination, whether it's increasing or decreasing, and then just their vitals overall, right? Because this person, like I told you, they're gonna be in the hospital and you're gonna be monitoring this anyway. They're gonna be hooked up to these things. So remember what your monitoring parameters are, and then kind of why, right? I already said the dopamine. That should make you remember, oh yeah, the urine output. Because our other meds, we're not really worried about that. Adverse effects look very similar to what we already saw, and then our interactions, the same. Okay, we already saw those. So as we keep going, you see how you can just kind of group them, and there was only a couple things where you're like, okay, like let me remember this for that particular drug. So group everything together so y'all can remember what the side effects are, so you can remember what the your contraindications are, your interactions, your drug interactions, because they were the same for all three of those drugs just now. Okay? Questions? We okay? Keep going. All right, so these are now looking at my synthetic, right? So I made these because I said we need something that's better than those catecholamines. They don't last that long. My COMT and my MAO are breaking them down too quickly, and I want it to last longer. I want to get this effect for a longer period of time. So this is where my drugs are coming in. So these are not natural. These are our meds that we make. All right, so we have our isoproterenol. When you look at this, non-selective beta agonist, so when I say non-selective, that means anybody can get it, right? Beta 1, beta 2, it doesn't matter. I'm just trying to connect. I need a receptor so that I can do my action. So that's why you see that it says equal. Non-selective is that I don't matter. Doesn't matter. Okay? And then your beta 1, we already said what it's gonna do, so therefore you're gonna see that increase in that cardiac output. Your beta 2 is gonna try to decrease that your diastolic, but remember we had bronchodilation, we had all of those different effects whenever we hit our beta 2. So very good medication kind of hitting both of those things. Your net effect though that you're gonna see is an increase in their heart rate when they're using this medication. So our use is gonna be bradyarrhythmias, right? So brady, is my heart going too fast or too slow? Too slow. So if my net effect that I just told you was to increase, that is why that is my use for this medication, okay? Because I'm trying to increase their heart rate. And then temporary use until you can get a pacemaker for your patients who have heart block. I don't need you to remember what degree. I won't trick you and put like first or second degree. Just remember if they have heart block, this is another indication for us to use this medication, okay? Don't worry about what degree it is. If it helps you, then you can remember it. All right, so things are going too slow and I need them to speed up. I'm focused on the heart because I'm looking at the fact that this is more beta, okay, more beta activity. Remember. Why do I have our inhibitory? Which receptor, beta 1 or beta 2, had some inhibitory action to it as well? Beta 2. okay? So remember that. When we're looking at our dosing, again, titrated, so don't need to remember anything except for the fact that you're titrating it to the response. And because I'm messing with their heart, I'm monitoring my EKG, right? Their vitals are gonna be monitored because I have direct effect on my beta receptors. Adverse effects, looking similar again. Because I'm hitting that beta again, I have that hyperglycemia that I'm worried about. So just make sure that you're keeping an eye out on that. Your drug interactions, we're repeating ourselves, okay? So same exact thing. Oh, I did want to point out something here. Whenever we were looking at this, the difference from what we were looking at previously, remember we had alpha and beta activity, and this one I'm telling you is beta, non-selective but beta. So am I worried about an alpha blocker? It doesn't matter because I'm not hitting that. That's not interacting with this drug that's focused on beta, okay? So that's why you don't see your alpha here. Okay, so it's just, all the other things are the same, but if I'm not hitting that receptor as a drug, it's not gonna bother me when I'm looking at my interactions. If I hit that receptor, then a blocker of that receptor is bothering what I'm doing, okay? Okay, dobutamine. So again, looking at the same things, the same kind of net effect. So direct beta 1 agonist, you see that I have more affinity and a large affinity for my beta 1 over my beta 2. And then, so those are like very minor as well as the alpha effects. So those are like not typically what you're using this medication for. You're typically using it because you want to get those that response and that bigger pump from the heart. So when we talk about that, that's why you see it used for acute decompensated heart failure. So for our patients who have heart failure, the supply isn't meeting the demand. So what's happening is their body is saying like, hey, I need more oxygen. And their heart is like, yeah, I'm tired, and I tried. And so it's like, there goes your pump, right? Your dobutamine comes in and is like, no, I need you to like meet this demand. So the force that you're having that contraction, this is like digging and making it beat harder so that we can help the heart pump while we're getting off that fluid. Because a lot of times your patients who have acute decompensated heart failure are going to have a lot of fluid on them as well. Okay, so you're going to diurese them, you're going to do all the things we'll talk about in next semester. So again, monitoring that EKG because I'm affecting the heart. I'm beta heavy. So I'm more worried about what's going on with their heart. Adverse effects, more looking at the fact that you're going to have more headaches. So yes, headaches are something that's common in a lot of our drugs, but I want you to remember it for this because that's the biggest one that you're going to see here. And then AFib could potentially occur, which is a type of arrhythmia that patient can have. We'll go into that stuff next semester. You're likely to see that AFib happen in a patient who has a history of AFib. If they don't have a history of it, it's not as common for us to see that as a side effect. Interactions, same thing that we saw before. The reason why you're not so concerned about those alpha blockers are because it's like a minimum effect, right? That we were seeing from this drug anyway. So it's not like it's not why we're using this medication, so we're not worried about it. Okay, this is a summary of what we looked at for all of our direct acting, whether they were the ones that I made myself, so my endogenous, or my meds that I made to make my endogenous better, okay? So this is a great summary slide for you to review after you have like looked at your meds, okay? What this is trying to say is, hey, what drug is hitting what receptor? So these are all of our drugs that I have, and these were all of the receptors that we just talked about. So this is telling you your epi likes alpha over your beta. This is telling you that your norepi is hitting your alpha and your beta, but it likes your alpha more than it likes your beta. Your isoproterenol was strictly beta, so it's summarizing this for you to tell you. Remember, if you're remembering what your receptors do, this slide is kind of essentially telling you everything that you need to know as far as what I would be asking you on the exam. Looking at your dobutamine, I have more beta 1 activity, right? I'm getting that big pump that I need versus me worrying about any of my alpha or my beta 2 activity. So I'm not even worried about blockers of alpha or my beta 2 because it's very minimal. And then looking at your dopamine, again, varies depending on what my dose is, right? So just looking at this, you have low dose, your dopamine receptors are getting hit more, as well as your medium dose, but now you have your beta 1 getting a lot of activity there. And then your high dose, again, beta 1 is getting more of the activity. Now you have some alpha activity as well, okay? So when we're looking at this, I just want you to make sure that you're understanding kind of like the affinity that the drug has for those receptors. And then I wanted to go back real quick because I wanted to make sure I didn't do that. Okay. All right. Let's take our break. 10 minutes, come back, and then we'll look at our non-hypertension. Yes, you guys did. What's up?
I didn't even like hesitate. That's what was it for, yes. gonna flinch, I'm just like, because then if I flinch, then they're like,
Okay, I'll let you make a comment about it. If it won't be the other one, it's probably back.
you're like, tell us, please.
Charge me for the best computer.
Aren't they all?
Oh, yeah.
It's like a rite of passage.
Some of them better.
Oh man, that shit's something. And then at the end, and then you will have the problem. Then it's like,
That's like the worst when I'm like, I need this, I need that. And I go and I'm like, I need to get this.
You know what I hate is when I have to buy like stuff that you normally have on hand, like more of it, like buy more sauces or stuff. So like make my like if I have something in the house like sauces or like simple stuff like flour and whatnot, then like groceries would simply smaller and cheaper. But we'll have to buy the additional stuff I keep on hand. That's pricey.
I know sometimes when I have anything,
you're learning this just like.
It's around beer. Now I'm down.
Yeah, I don't see why not. Look, man.
I love the cold.
I love the cold too, but you get to a certain point. Like, I love the
Yesterday was a little extreme.
I love the cold.
You're from Maine, so I don't love
No, because I am from Miami. I can deal with the heat, but I love the cold. I hate
Yeah,
snow.
I'm from Texas, so I don't like the heat.
So I love the
We grew up without it, so
yeah. So I love the cold, but when I'm able to like bundle up, I love wearing jackets. So like, if I can have a jacket, like I want to keep it cold, so I wear my jacket.
one of those people have sweaters because of the
Oh, fuck no.
I think naturally if you get colder,
Like, I have this feeling about because of the time I sweat so much. So like I have to sit with the fan like directly on me.
I need air circulate and like if there's not a fan going or a window open, like I'm gonna get nauseous.
Yeah, I need a fan. My wife needs like multiple blankets.
I can't sleep in a room that has no
Florida has no windows, so that's why I'm just like I enjoy the cold when I can.
This last 2 days, I've like gone outside and it was like, it was like 60.
Yeah, like 68, 70 degrees.
And I walked inside, I'm like, it feels stuffy. It's a new something died. You know, just like
That chicken that you get in the back corner dying. So you go to the we'll call it the HEBs that just in grill.
I don't have any around here. They had them in Hood and they had them in
Yeah, all those things are yeah.
I love the good like they do like the go back.
Yeah, it's like the HEB, like my HEB is the one I guess my house has, and then there's one a little further down, it's a huge one, and that one has even bigger the thing for. And you can always get like a grilled egg quarter or something. It was really like one of the first meals I had when I moved to my house. Like I've done fast food with HEB and just bought like a bunch of like itself.
My friend must like have a birthday to her mom here, so I text her mom. It's like my birthday was in July. Your daughter's telling me I'm The one I have is a barbecue, that true barbecue.
True barbecue is good, yeah, the true Texas barbecue. What's the like? They usually will, the smaller HEBs will have one or the other, and like the really big ones will have both. And those are really good. Like we leave my house on the Chico, and that one, that one was fucking good. The one right next to my house, right down there, didn't have a Chico.
The one that could happen, the one that was,
I remember the one up in
the one all the way, what's that area?
so because there was no, there was
Like in another little town.
like up at the Wilcox. Yeah, that was because the clean one didn't have. I think that one didn't have. That one didn't have. The one Harker Heights is right here. Like how big it was.
It's really nice. You know, that's something I see.
I've been taking it. It's not really.
Where I'm at, there's that nice one, there's these smaller
Yeah, like Buffalo might have a. I mean, if you want me to grab it, you can bring it so you can take it home.
chicken like that.
You told me to quit. Absolutely not. I still like it.
All right, you ready? Tyler, Gordon. Okay, we're gonna keep going now with our adrenergic agonists. So these drugs are essentially still mainly exciting things. And before I do that, sorry, I wanna go back real quick because I had a few questions about it. And I wanna kind of tell y'all what I'm looking at when I'm looking at these. So when I'm looking at this, right, I'm not gonna specifically like ask you a question directly about like what a beta receptor is doing. What I'm expecting for you to know is when you're looking at your drug, like, hey, what am I expecting to see from my drug that is hitting this receptor? So when you look at this and you kind of get this, it helps you as you go through your drugs to remember what your clinical indication is and to help you understand why you're seeing some of the side effects. If you don't want to look at this or learn this at all, you don't have to. You need to understand what's happening with the drug. It just makes it a lot easier and clearer for you to associate it. So that's why I say, and I give the advice for you to look at it in the sense of what are these receptors doing so that your clinical uses and your adverse effects make sense. Your interactions make sense, okay? You don't have to. Now, with this, let me get my little laser pointer. These three things that are on the bottom of your beta 2, okay? These three things are things that are essentially like excitatory. If you were in a fight and you needed these things to happen, right? Like you're trying to make it, these are things that are going to increase like glucose, right? So increase sugar. When we look at that, that's hyperglycemia. Okay, this is essentially saying like, hey, things are going up, like it's excitatory. So try to kind of remember that when we look at beta 2, we have a lot of things that kind of are inhibitory. All this stuff kind of up here kind of reminds you of like inhibitory actions, but you do have some excitatory function in there as well. Okay, so I try to help you remember it that way. Okay, back to, there was one other. Okay, so my non-catecholamines, they're still direct, okay? They're still gonna directly act on our receptors, but what we did to try to make these last a little bit longer and to give us some options to have different formulations was we removed the hydroxyl group. So now that I removed that hydroxyl group, I'm able to kind of hang out for a little bit longer, okay? You don't see it on, like how we have it here on our catechol group. We removed one of them, so now it's like, I can hang out a little bit longer. I can do your effect a little bit longer, and I'm not worried about the COMT and the MAO as much. We'll still see them kind of have interactions with our drugs, but they're a little bit, these drugs are a little bit more resistant to their action, okay? So looking at that, we increase our action of that drug, right? So now I can hang around for a little bit longer. And then you also see that because I did that, I'm more resistant to that COMT and the MAO, so I have now oral options. Everything that we talked about before, we were looking at IV, IM formulations of them, right? I had to inhale it, I couldn't take it orally like swallowing a pill, okay? Now, this is going to introduce us being able to do that. So we manipulated that drug to say, hey, I need you to stay around longer, and I need some other options to still do some of these very similar actions with my patients, okay? Improve CNS penetration because I have lipid solubility. So now we're also going to see some more side effects that are occurring from them now being able to penetrate the CNS a little bit better. One of our drugs that we have, this one is still just IV. We will see this used, you have phenylephrine. When we look at phenylephrine, again, I already told you that it was direct acting, but this is one that is going to focus heavily on the vasculature, so alpha-1, okay? When we look at how we're using this, when we talk about this, is more so looking at that vasoconstriction that we need. So again, when we're talking about this, this is for our patients who are in some type of shock, okay? They are very hypotensive, and we're trying to bring that blood pressure back up. How they got into shock could vary. Our job is to try to get them back up. And then you see myodratic for your eye procedures, because when we hit our alpha-1 receptors, we saw that we had mydriasis, or that dilation. Remember we talked about that, and y'all were like, oh, this is what it means. That's because of us hitting that alpha-1 receptor. So again, relief of eye redness, hemorrhoids, and nasal congestion. We formulate this and we kind of compound this sometimes in the pharmacy to where people who have hemorrhoids where the vessels by the anus have like swollen really bad and they're bleeding. Sometimes when we put this in our topicals, it helps them kind of vasoconstrict, so it gets some of that fluid out of there for them so that they're not as swollen and they can use the restroom a little bit better. Okay. So when we're looking at our alpha-1, we said already that it was excitatory. Looking at our monitoring, because I'm working heavily on that vasculature, right, and I have a lot of vasoconstriction, I am worried about monitoring this patient's blood pressure. My adverse effects still look very similar, right, because I have that IV option when I'm looking at one of these meds that are agonists. I have the extravasation that I'm worried about because it is IV. Okay, it can always slip out of there and then cause my tissue to die around that area where I was doing the IV. Hypertensive headache, okay? So I have clamped down too much. And now I'm starting to experience a headache because my blood pressure went up really high. So you know how a lot of people who have high blood pressure, they're like, oh, I ran out of my meds and I knew that my headache was getting really bad because I knew my blood pressure was really high because my head was hurting really bad. Okay? Also, we can use some of these meds to say like, okay, I need you to pay attention to the fact that if your head is hurting, that is your alert to me to say this dose is probably too high. Okay, I clamped down too much. And then when we look at using this med, we have this available in some of our tablets also. When we talk about allergies, it's not my favorite. This is like one of those drugs that I hate for people to use for allergies, and we'll talk about that when we get there. But they can have rebound nasal congestion if they use it for over 3 days. Okay, so that's why when we talk about drugs like Afrin, or if we're looking at epinephrine, we'll say, hey, don't use this longer than 3 days because yes, it's helping with your congestion right now, but if you continue to use it, your body will then start to be congested. And so you'll see people walk around and they're using it all the time because they've used it over 3 days and now they have that rebound congestion. Looking at our interactions, we're worried about our alpha blockers and any MAO inhibitor that they use within the last 2 weeks. And when we start looking at like some of our antidepressants, things like that, you'll see some drugs that will inhibit MAO. And so we're worried about like them having that washout period in between, because if they have that MAO and they were taking this, we could increase their blood pressure even more, right? Because remember, then that drug is gonna hang out for a longer period of time now. And it's already resistant to these anyway. So now I've like shot their blood pressure up really, really high when I'm using an MAOI with one of these meds, okay? Oxymetallazone. So this is our Afrin that we were talking about. We're looking at this medication, alpha-1, alpha-2. We have this in several different formulations. So our nasal sprays, I guess is how I would say that, nasal spray. You also have it in eye drops. So when we're talking about people who have like red eyes and we're trying to get the red out, we'll sometimes use oxymetallazone or that phenylephrine for those indications as well. So relief of congestion and droopy eyelids, we'll talk about that. It's called Upneek for the droopy eyelids, but that's like a newer prescription. I don't even think it's on our formulary, to be honest with you, because we're the last to get everything. But it's called Upneek, and if you think about it, like it's trying to get their eye to come back up. Okay. And then looking at your dosing, don't remember the dosing. What I want you to remember about dosing, no more than 3 to 5 days. If I use it longer than 3 to 5 days, I can get more congestion, okay? And I don't want that to happen. When you see this rebound hyperemia, that's essentially them having extra fluid or extra congestion in that place, okay? So just think about rebound congestion. And then that ocular stinging and burning, especially if someone who has red eyes also has other conditions that are causing the red eye, this isn't fixing their underlying condition. This is just fixing that symptom of their eyes appearing red, okay? So if there's an underlying condition as to why, you gotta fix that. This is just helping their appearance. Most eye drops, when you put them in, especially if you've been rubbing your eyes, they're gonna burn, they're gonna sting a little bit. So typical side effect for the eye drop. All right, your midodrine. When we look at our midodrine, used to be a super popular medication, not so much anymore, but alpha-1 agonist, and then we see a prodrug. Okay, so we need to make sure that we have our SIPs working, right? Because we have a prodrug and then it has that active metabolite. Vasoconstriction, because I'm still worried about my alpha, right? So that's why I'm seeing my vasoconstriction, and with that vasoconstriction, I should expect to see my blood pressure go up, okay? So, increasing my blood pressure. Again, don't worry about the dosing. The only thing I want you to know about the dosing is that we try not to have people take this at night because they can get hypertension from them actually lying down, okay? Because you want your patient to know if they're experiencing that hypertension. You don't want them to be hypertensive in their sleep and there's nothing that we can do about it if their blood pressure went up too high, okay? So we try to make sure that they're taking this during their daytime hours, like while they're awake, and avoiding it for them taking it late at night. So no doses within 4 hours of them going to sleep, whenever that may be. So that's what I want you to remember about the dose. Adverse effects, okay? When I'm looking at this, my blood pressure goes up. I want you to directly relate an increase in blood pressure to the fact that you're probably gonna have your patient end up having tachycardia. My body is then gonna compensate for that, so that's why you see that you have reflex bradycardia, because your body said, hold up, slow down, we're going too fast, so your reflex bradycardia kicks in, okay? So try to remember, if I'm seeing vasoconstriction, it is likely that I'm going to see that heart rate go up, and I'm gonna have tachycardia, and I may experience, or what I should experience, is reflex bradycardia. Piloerection, or some patients having goosebumps from the medication, and then like those skin sensation or feeling numbness, kind of how like when your foot goes to sleep, is gonna be your paresthesia. Drug interactions, we are worried about alpha and beta. Can anybody tell me why I'm worried about a beta blocker, even though I'm not directly hitting that beta receptor? Right, that reflex bradycardia, right? So I have dropped them down too low if I'm giving them that with one of my beta blockers. And then again, that MAOI within 14 days. Okay? Clonidine. I like clonidine because there's several different ways that you can give clonidine, and I hate taking pills, so we have a patch when we think about clonidine. So when you see the Catapress TTS, that's the transdermal or your patch that you can put on your patient. So looking at this, alpha-2, was alpha-2 excitatory or inhibitory? Inhibitory, okay? So when we're looking at the effects of this, it's gonna help decrease that sympathetic outflow that I'm getting from my sympathetic nervous system being activated. I'm trying to calm things down, right? I'm inhibiting them. Okay, so therefore I see a decrease in that peripheral resistance, my heart rate, my blood pressure, all of that is going to try to help me drop it down. Okay, so my clinical uses, hypertension, we're starting to see this used a lot more because we are using it in our PEDS patients for ADHD, to try to use this prior to us using like a stimulant for them. So we'll see this now used a lot for ADHD. And then your other indications are off-label, but very prominent use in those situations as well. So nicotine, opioid withdrawal, and then your Tourette syndrome. So your people who have certain tics, you're just trying to decrease their sensitivity and their response, okay? Dosing, don't worry about anything with the dosing for this one, okay? So this is more, because I hit that alpha-2, that negative feedback, I'm trying to inhibit or decrease my fight or flight response that I'm having, okay? I'm doing the opposite of that because I'm alpha-2 when I'm looking at my clonidine. All right, caution. When you're looking at clonidine, and we'll talk about this more when we touch on beta blockers as well, but you want to make sure that you are tapering them off of this medication, okay? The reason why we taper them off is because you don't want to have them having unopposed, or if your body has been, what we just talked about here, stimulating or binding to that alpha-2 receptor and inhibiting activity, if I just pull this off, now I'm putting my body into shock because it wasn't working, my drug was doing this for me, right? So I'm slowly going to taper them off. The higher the dose of clonidine they're on, the longer they've been using clonidine, the more obvious it is that you need to taper them off of it, okay? So this is not one that you just stop. Our adverse effects, you're gonna see more with your oral than when you're looking at your transdermal. So we have drowsiness, dry mouth, skin reactions because if they use the patch, and that's only if they're using the patch. And then that retention of your sodium, and then remember, if I retain sodium, that water is gonna follow. Water follows salt. And it could get very bad to the point to where you may have to diurese somebody, so you would give them a diuretic medication, like furosemide or Lasix to kind of get the fluid off of them. But I like to tell y'all all the time, if there's a drug that makes you have to give a drug, see if you can give them a different drug. Don't give them a drug that gives them a side effect, and now you're trying to treat the side effect with a medication, all right? what else can I give you? Can I give you something else? Can I switch it to the patch and see if that helps you not retain as much fluid, okay? All again, a function of what receptor is binding to. When you see enhancing the AV blocking effect of your beta blocker, so if you're looking at this, different studies tell you different things. Some will say that you're gonna pull your beta blocker before you, pull your clonidine before you pull the beta blocker. You'll hear vice versa. Sometimes you'll hear where you're gonna take your beta blocker a couple of days before you stop the clonidine, so that way you don't have that unopposed alpha action in your body, like, hey, what's happening? Your body will go into overdrive, and so that's where you'll see that if you don't do this, you can have a huge surge in your sympathetic output. Okay, your body is like, what's happening, fight or flight, and it increases it. So if you taper off and you typically pull off that beta blocker first, you're gonna avoid that unopposed alpha action. Your body is gonna kick back in and say, okay, I'm ready for it. And then you'll pull your clonidine, tapering them off of it. You still have to taper them off of it, okay? And sometimes we'll talk about this too, you're gonna, depending on how long they've been on the beta blocker, you'll sometimes have to taper that beta blocker also. Bromidine or Alphagen, when we look at this formulation is an eye drop, so it's an alpha-2 agonist, so the same things that we've been talking about before, helping decrease that aqueous production that the patient will have, so you have more outflow, getting rid of it, okay, less pressure. So when we look at that, we're talking about glaucoma. Don't worry about the use, and remember, whenever I'm talking about a lot of these meds right now, whenever I'm putting in a drop, I'm looking at the fact that it may sting or burn our patient in the eye. Beta 2. So now we're looking at us specifically dealing with our betas. We talked about alphas, now I'm looking at beta. I'm agonizing my beta, okay? So beta 2 agonist, we said that I have 2 lungs, so when I'm talking about my lungs and my betas, I am doing bronchoconstriction or dilation? Dilation, okay? So if I think about people who are bronchoconstricted, I'm thinking about my people who have asthma and COPD. That's where I'm using these meds, and my patients who have asthma and COPD. Okay, so that's your clinical use. When we talk about the difference between our short and our long acting, when we look at anything that's short acting, it's acting fast, right? I need to get there, it's a rescue. So typically we'll say this is my rescue inhaler versus if I have a long acting, it lasts for a longer period of time, and therefore it's my maintenance. If you see that somebody is using their short acting a lot, that means that you're not doing a good job with their maintenance meds. So we gotta figure out how to control that maintenance, okay? Dosing is gonna vary. I'll show you a table, and I'm not gonna expect for you to remember that table. When we're looking at our monitoring, are my drugs effective in bronchodilating this patient? Am I giving them the right dose? So the way that you're gonna test that is you're gonna use your PFT and your PEFR to monitor that, to see like, okay, yes, these are working. My patient can breathe better. Their test results are coming back higher now that I put them on these meds, is what we should see. Okay, they shouldn't be as restricted. When we're looking at our adverse effects, increase in the blood pressure, tachycardia, because remember when we were talking about our beta 2, we had some excitatory, we had some inhibitory. So make sure that you go back at that slide again and look so that this can kind of make sense for you. When we're looking at our CNS stimulation, that's why we tell some people who are taking different beta agonists to not take them at night, because some patients will say like, oh, I feel very restless, like I couldn't sleep. Or you'll see where some people will take these meds and they're super sensitive to them and they're very jittery. So they have like that nervousness about them and like they can't kind of sit still, okay? So that is definitely something that you see with our beta agonists. Hypokalemia, hyperglycemia. When we're talking about our hypokalemia, this is dealing with like our sodium, potassium, ATPase, and so that pump will essentially shift potassium inside. You'll see sometimes also where we'll use this in certain situations to get that effect in certain disease states, and I will probably talk about that in some other classes. So sometimes we'll give a beta agonist for that. And then looking at your hyperglycemia, this was just looking at, again, that increase in our glucagon that was happening from us activating that beta receptor. interaction if I have a beta blocker, right? If I have a beta blocker, I am gonna say, well, I know you're trying to get to this beta 2 receptor, but I'm here, so no thanks, right? So now I'm giving my beta agonist for no reason. Okay, my drugs. So, on here you see several different doses. I do not want you to worry about the doses. We're looking at these are inhalers that we're using for our patients, except for that terbutaline. The terbutaline is tablets, not used very often. Most of the time, you're gonna treat your patients with albuterol or levoalbuterol. So, short acting, very common. When we look at this and we had to pick between the two, albuterol is typically your drug of choice. It's also a lot cheaper than you using levoalbuterol. But I want you to just remember that these are considered your rescue inhalers, and then that you have your albuterol used more so than your levoalbuterol. Okay. And then again, your terbutaline, know that it falls under that short-acting class, but not something that we typically use as a bronchodilator. They rarely now use it for that premature birth. OB may sometimes use it, but they don't use it that much anymore either. Okay? When we look at the side effects, and we're thinking about the side effects of this, because I am putting it where it needs to go, right? Because I have an inhaler that I'm taking a puff of and I breathe and it's going to that site, it's going to my lungs, I don't have a whole bunch of systemic effects. The higher the dose though, or the more frequently that I'm using my inhaler, the more likely I am to see those side effects occur, okay? Because now I have a lot of it in my system. I have a lot of it to circulate and go other places. But for the most part, if I am not having to use it so often, my doses are reasonable, I'm less likely to see that because it's going directly where I need it to go in the lungs. When you're looking at your long-acting, okay, you have Sympathetic, formoterol, indacterol, and arformoterol. What I want you to pay attention to on this side is what are your long-acting medications, and then looking at your comments, I want you to look at what is specifically for COPD. So if I give you indacterol and arformoterol, those are not used for your asthmatic patients. These are used for your COPD patients. Two different disease states, two different underlying causes as to why those disease states are happening, okay? So these two specifically are only used for your COPD. When you look at all of this over here about the quick onset, I don't want you to worry about that. They're long acting, typically they're used for maintenance. Yes, they have a quick onset, but we don't use them for like rescue inhalers. They increase the risk of asthma-related deaths because they may not work quickly enough, okay? So, Sympathetic, formoterol, you can see them used in either indication. When you're looking at indacterol and arformoterol, those are the ones that can only be used in COPD. No doses. Okay. All right, our indirect acting agonists that we have. So these are, again, not saying I'm directly doing something to make norepi get displaced. I am now indirectly doing something to displace norepi. Okay, so indirect agonists. These are some of our stimulants that we are looking at. So when we were talking about quantity, I can use that to kind of try to stay away from these. When I'm typically looking at these medications, I'm going to see that they're controlled medications. So C2 meaning I have a lot of restrictions, a lot of having to come and visit you, right? So this is something that we kind of let our patients graduate to, and some people, this is what they will need. They can't just deal with just quantity, right? Some people are going to need these meds, and sometimes you can use both of these together if you need to try to get that desired response that you wanted from the patient. So, Schedule 2 medication, which is very important. If this is a maintenance med, how many days can I give that patient? 90. I can give them a 90-day supply. Do I have refills? No. Okay. So, indirectly causing that norepi, you have some serotonin and you have dopamine that is going to be released. 5-HT is how you will see serotonin abbreviated, just in case I don't think that's what that. So this is how you're going to get those meds kind of pushed out there, and then I'm going to say I don't want you to reuptake these so that they can stay in the synapse longer, to bind to those receptors longer, to do and get that action done that I need. So ADHD and narcolepsy, right? I'm having more stimulation. I'm trying to like make you focus. I'm trying to make you not just randomly fall asleep with your patients who have narcolepsy, okay? So this is a stimulant. This is trying to get them to like wake up, respond, get those catecholamines out there into the synapse to keep binding to the effector cell to work. Adverse effects. So when we're looking at these adverse effects, a lot of CNS effects. And then when we talk about the schedule, this kind of makes sense, right? So when you're looking at this, you'll have a lot of people who have like psychosis that can happen, the suicidal tendencies. These aren't super common. If I have this underlying or I'm predisposed to some type of mental illness, this may be more likely to occur, okay? Versus if I'm just a normal, healthy, like there's nothing that was predisposing me to feeling this way, I'm typically okay when I'm using these meds. So the dependence, that is a big reason why you're gonna see this listed as a C2. What we do have a lot of people coming back and saying is like, they're very jittery. So you'll sometimes see, like, think about if I like made norepi is just like raining, okay? And like the person is just, I just think about like if they don't have something to focus on, it's like, where do I put the energy? Where am I putting my hands? Like, what am I doing? Okay, that's kind of how I think about this. Cardiovascular, things are going up, right? They're jittery. So I have palpitations, right? Like I feel like my chest is, my heart is beating out of my chest like they had a big dose of caffeine, okay? And then nausea, vomiting. Another one as to why this has high dependence is because of the anorexia that can happen. So you need to make sure that you're watching out for your patients who have bulimia or any issues with like weight loss, because those are the patients who could be also abusing this medication and using it because they're losing weight, because of the nausea and vomiting and because of the decreased appetite that some patients will feel. With your PEDS patient, another reason why we try to stay away from these or have as low a dose as possible is because it can cause growth retardation in some of our patients, okay? So just make sure that you're not just handing this out, which is kind of what we've been doing these days with some of these meds, and try to see like, hey, have we tried behavioral modifications first? Not to say that the patient may not end up on these meds, because some people do need them, but a lot of people may not need them, and this is the easier way out for us to do that, right? So, hey, let's try these things, let's talk about these things. And your kids, make sure that you're also watching out for their weight, okay? Because this can decrease their appetite, you can start to see weight loss in those patients, and that's also what could potentially be causing them to have that decrease in their growth, okay, and stunting their growth. So this, when you're putting them on it, especially if it's a PEDS patient, monitor them. Contraindications. So I just told you about all of the things that could potentially happen. If any of those things are already an issue, don't give them this med. When you're looking at cardiovascular disease, that's because, right, I'm speeding some stuff up. But what you're not thinking about, or what we haven't talked about yet, is this hyperthyroidism. Hyperthyroidism, their heart rate is already up. They're already tremoring and all over the place when we're talking about the thyroid being messed up. So that's why you see your hyperthyroid on there, and then you have glaucoma just because of the increased pressures that we're going to have happening, okay? And then your drug interaction, we're looking at our MAOI. Tyramine. When we talk about tyramine, it's not something that is a drug that we market, more so than it's something that's present in foods that people eat, okay? So when we look at tyramine, you're essentially having this and tyramine and norepi not be broken down. And both of these things are catecholamines now that would just be floating around in our system and acting on those receptors. So what we see is a net result of like arrhythmias happening, hypertension happening. So we're watching out to make sure that if somebody has tyramine and they're taking one of our drugs that we previously talked about, like we're definitely saying avoid these foods or eat them minimally, and if you do eat them, we need to make sure that we're watching out for their blood pressure, making sure that their heart is okay, all of those things. When you're looking at this tyramine with the MAOI is considered a medical emergency and can lead to a hypertensive crisis. The reason why is because, again, now I am not breaking these drugs down, like what I was just telling you about. I'm not breaking those drugs down. So they're hanging out and they are stimulating and activating everything. And I'm going to end up in a crisis. I will potentially have a hypertensive crisis or urgency, if not emergency. An emergency is when like the organs start to get damaged if you don't recognize quick enough that your blood pressure is that high. We look at some MAOIs, and we'll talk about these because we haven't really looked at a lot of these drugs, but we have like things like linezolid that could be considered an MAOI, phenolzine. So we'll talk about some of these drugs later, but you'll hear about the drug class MAOI, and those are the drugs that we are worried about if they take with tyramine, that they can end up in this urgent situation, having that crisis. I will tell you that it is an MAOI. So I don't need you to remember what drug is considered an MAOI. I just need you to know if they have an MAOI with this tyramine, that this could happen. And anywhere else where you see like MAO inhibitor, that's an MAOI. I would just tell you that, and you will need to know, oh, this is a interaction with my medication, or this is an interaction that's happening with tyramine. Okay. These are the different foods that you can see. So they're in a lot of fermented foods, and then like we just talked about, that crisis, if you're taking an MAOI, because you're not going to break it down, you'll have too much more epi around. So if you have somebody who likes pickled things or aged cheeses, all of those things are where you could potentially see a hypertensive crisis happen, okay? So that is if they're doing the tyramine with one of your MAOIs, okay? Or that food with an MAOI. All right, cocaine. We should not be cheering for cocaine. Because we can't do cocaine. No, we should not be doing cocaine. No one should. Okay, cocaine is bad. Cocaine is bad. So, when we look at this, right, when we talk about schedules, this one is just one that's very interesting, right? Because we think about this is like an illicit drug. We shouldn't really be using this. But when we talk about research, you're gonna see that this is used a lot. When we look at back in the day, how they used to use cocaine a lot for like anesthetic purposes, and things like that, like you could see it. Do I see this used? I have never yet seen this used. Even when I was an inpatient, I never saw it used. But could somebody potentially use it? Yes, they could. But our mechanism of action, and we don't even stock this in the pharmacy, now that I'm thinking about it. I've never seen this even in the pharmacy. So when we're looking at our mechanism of action, essentially we're trying to say, I'm gonna leave norepi and epi in that synapse for as long as I can so that I can get the stimulation, right? So I think about, what was that movie with Leonardo DiCaprio, Wall Street, or whatever? That's what I think about, or like Pulp Fiction, okay? So you're essentially just, like, the longer that you can keep that medication or cocaine on that mucosa, the more stimulation that you're gonna see. When you're using it topically, what you'll see happen is that it reduces the nerve impulses. So essentially it's blocking you from feeling pain, from feeling anything, right? Because now I've desensitized it. And the longer I'm on there, the more I'm going to desensitize that area, the more I'm gonna not have that response. So that's what you're seeing there, that blocks the initiation or conduction of the nerve impulse following local application, which is how we used to use it a lot in dentistry. So topical anesthesia is where you are seeing that. What we remember and think about cocaine is where nasal cavities, right, where people will like snort it, or you'll see where people use, when they use cocaine, they'll put it like in their, take it, put it in their gums. So the same thing, right, it's going onto that mucosa, and it's topically, they're numbing the feeling. You take enough of it, you're numbing everything, right? Adverse effects, right, that stimulation, and then you can have where you also have depression that occurs from it, especially in people who are having that already kind of underlying, those underlying issues, you can definitely see that. And then cardiovascular wise, if you take a lower amount, you can see bradycardia. You take a higher amount, you can see tachycardia. And then with the high dose of tachycardia, you can sometimes see reflex bradycardia. So just like this drug is a super complex drug. We don't really use it, but it is classified as a C2 medication. You'll also see vasoconstriction happening as well, okay? Don't need you to remember the dose for a fatal overdose, but just understand that they can overdose from cocaine, clearly. When you're looking at somebody who is a cocaine user, and it's not on the side, but when we're talking about a beta blocker, these two things can be very, like, you can have an unopposed alpha action with these two meds as well. And so this could end up very bad for a patient. So if you have a patient who you think may have used cocaine and you're gonna give them a beta blocker in the hospital, ask them, because you could potentially, like, you could mess them up with that, okay? So just a cautionary tale, and then we'll stop here today, and we'll start here tomorrow, okay? We'll finish this tomorrow, and then we'll do our anesthesia lecture as well tomorrow, okay?